Hyperkalemia. Etiology: high volume, high potassium cardioplegia solutions used in the operating room. The potassium load is usually eliminated promptly by normally functioning kidneys, but hyperkalemia can be problematic in patients with intrinsic renal dysfunction or oliguria from other causes. Low cardiac output states associated with oliguria. Potassium levels may rise with alarming and life-threatening rapidity. Severe tissue ischemia, whether peripheral or intra-abdominal. Peripheral is from severe peripheral vascular disease or complication of an intra-aortic balloon pump. Intra-abdominal is mesenteric ischemia. Hyperkalemia is often the first clue to the existence of these problems. Acute and chronic renal insufficiency. Medications that impair potassium excretion or increase potassium levels, ACE inhibitors, potassium-sparing diuretics, non-steroid anti-inflammatory drugs, angiotensin receptor blockers, beta blockers. Note: remember that hyperkalemia is exacerbated by acidosis, which often accompanies low output or ischemic syndromes. A 0.2 unit change in pH produces about a 1 milliequivalent liter change in serum potassium concentration. However, in conditions of organic acidosis, the potassium is more likely to rise from tissue breaks down and release of potassium from cells, lactic acidosis, or from insulin deficiency and hyperglycemia, ketoacidosis than from a change in pH. B. Manifestations. Manifestations are predominantly electrocardiographic due to depolarization of cardiac cell resting membrane potentials that decreases membrane excitability. An asystolic arrest may occur when the potassium rises rapidly to a level exceeding 6.5 milliequivalent level. The ACG chains of hyperkalemia don't always develop in classic progressive fashion and are more related to the rate of rise of serum potassium than to the absolute level. These changes include peaked T waves, ST depression, smaller R waves, prolonged PR interval, loss of P waves, QRS widening, bradycardia, asystole, ventricular fibrillation. When the heart is being paced, hyperkalemia may result in failure to respond to the pacemaker stimulus. C. Treatment. Treatment entails stabilizing the cell membrane, shifting potassium into cells, and increasing its excretion from the body. Table 12.8. First, it is essential to identify and remove any potential source of potassium intake or medications that may increase the potassium level as above. Use a low potassium diet in patients with renal dysfunction and persistent hyperkalemia. Second, optimize cardiac function. If there is evidence of advanced cardiac toxicity or ACG change, usually when the potassium is more than 6.5 milliequivalent liter, administer calcium gluconate 10 milliliter of a 10% solution IV over 2-3 minutes to stabilize the cell membranes. Note that calcium should be avoided in patients on digoxin. Second B. Alternatively, calcium chloride 5 to 10 milliliter of a 10% solution 0.51 gram can be infused through a central line over several minutes. 3. Shift potassium into cells. 3A. Regular insulin 10 units in 50 milliliter of a 50% dextrose solution IV. This should lower the potassium about 0.5-1.5 milliequivalent liter within 15 minutes and last for several hours. This can be considered first if there is marked hyperkalemia but no ACG change. 3b. Sodium bicarbonate. Sodium bicarbonate, 1 ampoule of 50 milliliter of a 7.5% solution with 44.6 milliequivalent, or an 8.4% solution with 50 milliequivalent, should be given to raise the pH to 7.40 7.50 if the patient has a metabolic acidosis. This will lower the serum potassium in about 30 minutes with an effect that lasts for several hours. Bicarbonate also has a direct effect on hyperkalemia independent of a change in pH. In hyponatremic patients, the sodium load may reverse some of the ACG change of hyperkalemia. Third C. Beta-2 agonists activate the natrium sodium potassium ATPase system to drive potassium into cells and can lower the potassium level by 0.5 to 1.5 milliequivalent liter. Recommended drugs include albuterol 10 to 20 milligram in 4 milliliter normal saline by nebulizer, which has a peak effect in about 90 minutes, or an infusion of IV epinephrine 0.05 nanogram kilogram minute, which achieves its peak effect in about 30 minutes. Enhanced potassium excretion. Furosemide 20 to 40 milligram IV is very effective in reducing serum potassium in patients with well-functioning kidneys. Higher doses may be required in patients with acute kidney injury or chronic kidney disease. Sodium polystyrene sulfate enema, K-xylate enema 50 gram in 150 milliliter of water can be given every 2-4 hours. Note that sorbitol should be avoided in an enema because of an association with colonic necrosis in early postoperative patients due to decreased colonic motility. Alternatively, 30 gram in 60 to 120 milliliter of 20% sorbitol can be given orally up to 3 times daily. Each gram may bind up to 1 milliequivalent of potassium. This is a reasonable first step in the stable postoperative patient with a slowly rising potassium more than 5.5 milliequivalent despite withdrawal of contributing factors. Hemodialysis may be indicated if the above measures fail to lower the potassium to adequate levels. It can remove up to 50 milliequivalent of potassium per hour.